Hi, I'm Tony DeMaria, and I'm here continuing our conversation about the highlights of the TCT meeting in San Francisco with Drs. Deepak Bhatt and Jeff Popna. And turning to you, Deepak, I guess the OPTIMIZE trial got a lot of attention.
It sure did, and it was published simultaneously in JAMA. So this was a trial, and I should mention I was on the steering committee. This was a trial of 3 months versus 12 months of dual antiplatelet therapy in patients who had received a particular type of xodarolumab-eluting stent I would categorize as a second-generation drug-eluting stent. And what was found was that the 3 months was non-inferior to the 12 months. That is, there was no evident increase in the risk of ischemic events. There was a trend towards more bleeding with the longer duration, as one might expect. The event rates were low for both ischemic events and bleeding events, but still, I think the data provides some reassurance that if you have to discontinue dual antiplatelet therapy earlier, say patients having nosebleeds or something like that, it seems to be reasonably safe with second-generation drug-eluting stents.
All right, well, I'm kind of interested in that. You guys are interventionalists, but it strikes me that if we go back to the SCAR presentation that kind of shook the world about late stent thrombosis, that there was this tremendous reaction that we need to treat these patients for a good long time to prevent late stent thrombosis. And it may be the pendulum is swinging back because the data we had actually was not very strong, and all the data that seems to be emerging here and at other meetings is that a shorter duration of at least dual antiplatelet therapy is adequate.
Yeah, there might be another aspect of that too, is that most of the data that we accumulate for the very late stent thrombosis, in particular with the first generation stents, and so with Cypher-Taxis, the polymers that were used at that time did have a deleterious effect to the vessel wall over time. So those events were likely real, and I think that all of us who did this in those days of 2006, 2007 are very aware that we did have cases both of stent thrombosis that was after the 90-day period, and we had stent thrombosis that was after a year. What's really happened since then is we've just gotten better stents, and we've gotten reduced size of the polymers. We've got smaller, more flexible metal designs beneath them. And in the particular case of the Endeavor stent, this had a phosphorylcholine coating on it, which is almost an antithrombotic coating. Another report here at this meeting with PROTECT 2, there was actually less very late stent thrombosis and less MIs associated with the use of the PROTECT with the Endeavor stent. So I think two things probably happened. I think you're right, we probably got better and smarter, that's true, but also we have better stents available to us now. And so maybe we do have to change the script just a little bit, because now we have different stents that serve as the platform of what we do.
Yeah, I think that is a real change.
Are you ready to go to 6 months?
Well, first of all, there's 3 months in this study, but I agree with Jeff, first of all. This is a real change. The second generation drug-eluting stents really do have a lower risk of stent thrombosis than the first generation, and some might even say a lower risk of stent thrombosis than bare metal stents. There's data to support that. But for the time being, I would still say stick with the guidelines, which say 12 months of DAP, both for ACS, irrespective of whether patients are getting stented, but also separately for DS. But I think this accumulating set of data, including OPTIMIZE, suggests that if you have to stop early for some reason, it's probably not that high risk a thing to do.
Yeah, that's really the message to me has been, for the patient who needs some kind of a procedure and they're in their 9 months of DAP, I'm much more likely to say, stop, go to a single agent and have your procedure.
And the registry data support that as well.
Yeah, absolutely. Now, ARCTIC-INTERRUPTION was another interesting trial.
It was interesting, but for a different reason. So it really also addresses the perception of physicians about how important the dual antiplatelet therapy is. Just as a footnote, there were about 2,400 patients that were initially treated with stents and then included in the study, but at the time of 1 year, about 1,100 of those patients came out of the study because the physicians felt they should continue the dual antiplatelet therapy. So lose almost half the patients.
Right, and maybe the highest risk patients.
In the highest risk patients, but still left with then about 1,300 patients and randomized to dual antiplatelet therapy or to single antiplatelet therapy and then followed for 6 to 18 months, average about a year or so. And that didn't have no benefit of dual antiplatelet therapy in that subgroup. But I still find it fascinating that there was a substantial number of patients that at 1 year the patients said, I know the data, but I'm going to keep this going. I don't want to put the patient, it's not ethical to randomize the patients to stop the dual antiplatelet therapy.
Yeah, I agree with you. I mean, it makes doing these trials a bit challenging, of course, right? Because we want an answer that is generalizable to our entire patient population. And while we didn't get that from ARCTIC, I think it does give us further evidence that in lower risk patients, probably there isn't a benefit of just protracted, indefinite durations of downtime.
Yeah, there's always the danger. I agree with you, and we see this in the literature all the time where there's a low risk population that's segmented out, and the data are very applicable to them.
Yes.
But there's still room for the thoughtful physician to say, well, this particular patient doesn't fit into that group.
There's just one other little piece which I'll throw in. It's a longer discussion. We'll have to do probably an hour segment on it, but it's not the stent as much. It is the patient and the work that Deepak has done to say that active plaques, people that have acute coronary syndrome, rupture, that the dual antiplatelet therapy may be a different benefit in those patients
Yes.
than those patients with stable disease. And now we're focusing more not on preventing stent thrombosis,
Right.
but actually preventing recurrent MIs.
Yeah, I agree. It is important to realize the stent's only one part of the picture, and the stents have gotten better. But the underlying plaque that's bringing patients in, that hasn't gotten any better.
Yeah. So from my vantage point in imaging, looking at CT angiography, I think that the uptake of this procedure has been much less than was anticipated. I think in large measure because of the percentage of patients in whom the study is either not definitive or where it's in a very intermediate range, largely because of calcification and the potential to do FFR by CT would have an enormous impact on those patients if one could couple a physiological effect with the anatomic effect from the CT angio. And using that HeartFlow algorithm, the next study was done that showed, in fact, that with an improvement in the CT technique itself and some refinement of the algorithm, that the correlation with FFR became very, very good and probably clinically applicable. So
I agree with you. I think this is absolutely fascinating. I mean, for interventionalists, we've evolved from being anatomists, I guess, from just looking at the coronary stenosis severity and saying we need to couple that with physiology. So I'm an avid user of FFR and intermediate lesions to try to sort out if that lesion is important or not. But if I had both the anatomy and the physiology before the patient came to the cath lab, that's amazingly useful tool. And you're exactly right. The limitation that we've had with CT is it's just told us anatomy and hasn't given us a physiology. So the very complex algorithms using computational flow dynamics to get to the right place for finding what the FFR is are very sophisticated, but I think they're going to be incredibly useful. I mean, I think that would be amazing for us.
I absolutely agree. I mean, it's basically one-stop shopping, right? You get the anatomy and the physiology.
Absolutely.
Yeah, I take it.
Well, I think it's going to get better and better as time goes on. We're at the beginning of this kind of analysis, and as CT gets better, as the actual acquisition of the data gets better and the algorithms get further refined, I think it's going to provide an important pathway toward intervention. Well, this has been, again, a fabulous meeting, TCT 13. The science has been equal to the venue of San Francisco, and I think we'll all take away with us a lot of information that will apply in our practice. For CVN, I'm Tony DeMaria.